So welcome everyone to today's webinar. It's really nice to have you on in live. Of course, we are recording it so that everybody that was interested, there was a lot of people interested that they can go back to the YouTube channel and watch it. Today's webinar is about women, power and cancer. I'm bringing up the local perspective of the Lancet Commission results and recommendations. So tomorrow is Women's Day, and we wanted to contribute with this conversation and bring the perspective of cancer. The topic of this year is Invest in Women, Accelerate Progress. So it couldn't be more aligned with this Lancet Commission on Women, Power and Cancer. So for this reason, today we're bringing one of the co-authors of the commission, Dr. Verna van der Puy, whom I'm very honored because soon we're going to be working very closely. And she's going to be sharing the results of that commission and also her perspectives on personal perspective on it and recommendation. We also going to have with us three of our local stakeholders. So three of our, how do I say, agents of change that are working in the cities with us, driving change. So we have with us Fátima Luna, who is the Chief of Public Policy Projects of Fundación Peruana de Cáncer from Arequipa, Peru, and she's part of our City Executive Committee. We also have with us my dear Professor Nur Aishab Taib, Senior Consultant Breast Surgeon and Professor of University of Malaya from Greater Petaling, Malaysia. She's also a core member of the City Executive Committee in Greater Petaling, in one of SICAN cities. And we also have Professor Jessie Kitanga, which is Associate Professor, University of Nairobi and University of Maryland from Nairobi, Kenya, and also one of our key stakeholders. So today's webinar is in collaboration with one of our key partners, I would say, Siemens Healthineers. You all know recently in Davos, we launched our 5-year partnership. And in the conversations, in the journey of that partnership, there was one thing that was non-negotiable for Siemens, which was improving health and gender equity. It was not part of the discussion. It was like, this is Isabel, this has to be part of our partnership. It's something that is core for all of us, and especially for Tisha, whom I'm going to introduce now, and the CEO. So as part of this, we're co-hosting this webinar with them. It's part of our joint efforts to elevate the local voice and find solutions. And at the end of the webinar, stay tuned. We have both Siemens Healthineers and SICAN an announcement. So with this, I would like to pass it over to Tisha Bodman, which is the global access to care leader in Siemens Healthineers. And of course, despite being a partner, she as a woman, she's a leader, and she's also very, very into this theme and supporting and making sure that we advance in this journey towards gender equity. And I have to say that for the last years I've met and I've seen the way that she's transforming the way the company is addressing equity to access to cancer care and gender equity. So Tisha, over to you.
Thank you so much, Isabel. That is quite an introduction to live up to, but it has been a true pleasure to get to know you and the SICAN team over the last couple of years. So first thing I'll just say is I do head access to care. What is that in Siemens Healthineers? That's our focus on expanding our business and, more importantly, our impact in low and middle income countries. So we work across all aspects of healthcare in low and middle income countries, and cancer is a very special topic for us. So if we could go to the next slide, I want to talk a little bit about the partnership first, and then I'll tell you a little bit of my personal story. So we announced this partnership, as Isabel mentioned. It is 5 million Swiss francs, 5-year commitment announced in Davos. And the first element of the partnership is really around expanding access to breast cancer and high quality breast cancer diagnostics care. We have been funding a project in Cali, Colombia with SICAN for some time, and we want to expand that to a couple additional cities. We are also working in capacity development and in the topic of training and education for really all aspects of the cancer pathway. So from diagnostics through to therapy and survivorship. Digital health, another important topic. In digital health, it's quite special. We will be funding the program to baseline the different pieces, the different elements of digitalization that the different CCAN cities are using. It's quite a web out there, as you know, right? A lot of different technology is available, but not always interoperable. And funding the work where CCAN will put together a blueprint for what digitalization could look like to enable the cancer pathway. And then finally, this important topic about gender equity. This is part of our program. And as Isabel said, we'll be announcing a little bit more about that at the end of the webinar. So from there, I just want to thank all of you for taking time out as we get ready to enjoy International Women's Day tomorrow and to join us on this topic. I mean, for us, the CCAN partnership is very important because of the CCAN approach, right? We don't do this kind of partnership with everybody. And that's because of this very hands-on, in the country, multi-stakeholder approach and really building trust and leadership in the local organizations. And that's what, when the CEO and I and others involved in the partnership sort of look at CCAN, we say this is an organization that builds local capability, local leadership, and local trust. So that's really for us the founding reason why we would want to go further with CCAN. And this webinar and this topic of gender equity, of course, it's very important to our company. We believe strongly in the topic, but it's also very personal, right? I am a cancer survivor myself. I was diagnosed with breast cancer after finding a stage 2 lump in a self-exam about 4 years ago, right at the start of COVID. I have had chemotherapy, lumpectomy, mastectomy, radiation therapy, and all the fun that comes with tamoxifen, and now Aramedics, a new one, since then. But what was really special for me, I mean, I was in a high-income country when that happened. I was in Denmark and a great public healthcare system. But when I walked in the day to get my diagnosis, and I already knew I had cancer, I had actually read it in my digital health record, when I checked for my own biopsy results. But I walked in and there were 4 women in the room. One was to become my surgeon. The other one was the chief surgeon of the department. One was to become my oncologist, and the other was the lead surgical nurse. And these are the women I worked with for 10 months through that therapy. Now, it didn't have to be all women, and none of those women had experienced breast cancer themselves, but it made a big difference to me, right? I immediately felt a level of representation, of trust, of comfort to share some of my concerns. And that was something where I felt heard throughout the process, right? I knew that, when I had questions, I could get those questions answered. And let's be honest, in low and middle income countries, it's a different scenario. Women don't always have access to cancer care. They're not always heard in the system. They're not always putting themselves first when it comes to their health. So I think for me, it happened to be that one of my first trips after that was to Kenya, and I happened to meet a woman who said, yeah, my sister died of cancer, and unfortunately she was diagnosed super late, and she never wanted to raise the issue. And I just think for me, it's very, very personal to see what we can do to make a change there, right? So this Lancet report is super powerful. And I just want to close by thanking all of you for joining us in this important topic as we kick off International Women's Day. And I think with that, I will hand it over to Dr. Verna to get us started.
Dr. Verna, you're muted.
Thank you very much for this invitation. The Lancet Commission is quite big, and I encourage all of you to read the document. I'll just point out a few things that we came out of this collaboration. Next slide, please. So we are a collective group of 21 commissioners, 13-member advisory board, 7-member patient advocacy committee, 10 mentees, and backed by 25 organizations. And we are diverse in gender, geography, generation, and discipline. and together we came up with our findings. So what we found out in 2020, about 9.2 million women were diagnosed with cancer, out of which almost half of them died, who were women, and made up 48% of all cancer cases and 44% of all cancer deaths. We also find out that out of 3 million adults who were less than 50 diagnosed with cancer, 2 in 3 were actually women, which just shows you the burden of cancer in women, which cannot be ignored. Next slide. So what are the key questions that came out with this? We realized we look at sex, gender being adequately explored in relation to the cancer risk and survival. What and who drives the decision-making regarding cancer research? Who provides most of the care for people with cancer, and how are they valued? How can we ensure that equity is embedded into cancer-related policy making for all people of all genders? Next slide. So our key task was to investigate the preventable burden of cancer in women, apply more inclusive economic analysis to estimate the true cost of cancer impact in women, families, and society, take stock of the missing women in oncology leadership, broaden the evidence base to inform priority actions for a wide range of stakeholders, and to inspire transformational change in our approach to cancer. Next slide. So our key findings, sorry, I had a little bit of mishap with the slide. Our key findings, this is just one of the slides, is cancer ranks the top 3 causes of premature mortality among women, among all countries. The only problem we realized that for out of the 130 countries that were analyzed, about 40 of them who were in low to middle income countries, unfortunately most of them in sub-Saharan Africa, cancer ranked number 1 / with heart cancer. And you could say that this top 3 cancer tend to be changing over time in the high income countries and in middle income countries, and much more for men. But women tend to suffer most when it comes to the top 3 causes of premature mortality, mostly in low to middle income countries. And we also found out that overall cancer is less amenable to primary prevention in women than men. Most of the men cancers were attributable to tobacco and alcohol, which was easy to control. But however, in women, they had a lot of social determinants in terms of the gender norms that prevented a woman from undergoing preventive health services to lower the risk of cancer, or even education. And I mean, there's so many things that would marginalize a woman from being enrolled into preventive cancer services. We also found out that 1.3 million women's lives could be saved if just 4 key risk factors were avoided: tobacco, alcohol, obesity, and infections. In terms of tobacco, actually, in women, even though overall there's a less impact of tobacco uptake in women, we realize that in developing countries such as Africa, Latin America, Bolivia, and so many other countries, there's actually an increased incidence in the uptake of alcohol, mostly in the young people, and worst of all, smokeless tobacco, which tends to be impacting in the incidence of lung cancer in women. Not only that, we also look at smoke in terms of fossil fuels. Women tend to be more affected, and who are those who use fossil fuels in making food? It's more women in low to middle income countries. So that just shows you the burden. In terms of alcohol, we now know that alcohol intake there's a gender appropriation to the amount of alcohol that you can take that impacts your risk of cancer. So women need to take actually 0 or actually a quarter of what women take, but this is not, we are not educated on these preventive measures, and that will reduce our risk of getting cancer. And when it comes to obesity, we know that women tend to be more obese than men, and mostly in low to middle income countries, this impact is increasing, even there was much more in high income countries. What we also know that we talk about physical activity to reduce the risk of cancer. However, most of us have cultural norms and family obligations that prevent us from adequately increasing our physical activity, thereby increasing our risk of cancer, especially in low to middle income countries. Then we have the issue of infections. Infections are 3 times more common in low to middle income countries than they are in high to middle income countries. So therefore, the impact of infections is higher in women in low to middle income countries. Let's talk about HPV vaccination, for example. HPV infection leading to cervical cancer tends to be more, is increased more in low to middle income countries. And yet there's not that much that's being done just to, control that. Next slide. So globally, 52% of cancer deaths among women occurred prematurely. In sub-Saharan Africa, which is where I come from, 72% of all cancer deaths among women occurred prematurely. This compared to 36% occurring in high to middle income countries. So double the number of patients of women in low to middle income countries actually die prematurely compared to those living in high income countries. So, and then what we know now is that we could actually prevent these deaths through primary prevention and early detection strategies. We all know that most of the burden and the problems with prevention and early detection is worse for low to middle income countries across all cancers, most of all the breast and cervical cancer. And if women had optimal care to cancer, we could save almost 1 million women. And again, this is worse for low to middle income countries. Next slide. So in many countries, regardless of geographic or economic resources, women are more likely to lack knowledge and the power to make informed cancer-related decisions. In most places, like even for Bangladesh, when a patient has a breast mass, is actually attributed to a sin committed or a curse. So those are things that actually increase the stigmatization of early detection of breast cancer. Saying that women are too busy taking care of their children and finding money for the families, or have a taboo, have to ask permission from their spouses to be able to travel outside of their regions, mostly in the rural regions, to ascertain cancer care. So that the problems are different in low to middle income countries than they are for high income countries. And this needs to be looked at. Women are more likely than men to risk financial catastrophe due to cancer for the same reasons that I've elaborated. And I think the next slide will talk about that a little bit. Next slide. So what we found out is that 30% of women, 3/4 of women with newly diagnosed cancer, 30% of them or more will spend their annual household income on cancer-related expenses across board. However, women in upper to middle income countries spend substantially less of their income on cancer-related expenses. Okay, this was shown by the action study that looked mainly at in Southeast Asia. And we realized that in upper middle income countries, only about 30% of their income was spent, compared to a whooping 161% in low to middle income countries. So these women have to find money from somewhere, and this actually translated to a relegation of their duties to their families, to their children. In down the line, downstream, it caused a lot of psychological and financial issues to the family as well, and also the economy, because these women we know are make up a majority of the informal health sector and providing economic strength to their countries. Then again, to look at the unpaid caregiving, we found out that most of it was taken by women. And we found out that the caregiving work ranged from 2.3% of the national health expenditure in Mexico to 3.66% in India. And most of them this burden was carried by women. And again, these women are prevented not only from making money from their families, took care of families with cancer, relegating their own families and themselves. For these people are not going to be able to have access to preventive service or even travel for health services to prevent cancer or treat their own cancers down the line, which actually leads to it's like a whirlpool and causes more trouble, down the line for these countries. Next slide. So again, looking at women in the cancer workforce, the women in the cancer workforce actually experience more gender-based discrimination, including bullying and sexual harassment. There's a lot of data for high to income countries from the ISMO oncology workforce, from America, but there's not much from low to middle income countries. But we do have a good study from a surgeon in Malaysia who gave us a chronological history of how she became a surgeon and all the discrimination that went along with it. And a lot of females in the cancer identify, with this. Even the nurses who carry most of the burden of our work tend to have a lot of discrimination from male doctors and male physicians and even a lot of the women, even though we have a lot of women as nurses in our hospitals, the men are now taking over the jobs as leaders in the nursing workforce, even though for many, many years, nurses were the leaders in their work. So a lot of discrimination goes on. And there are so many more histories that it comes to that. Why is this important? We know that when women are in leadership positions, they're able to make good policies. They are able to make sustainable changes. They are able to recruit more women. And indeed, when it came to healthcare, we realized that patients who are taken care of by women nurses are able to uptake their preventive services much better. And even in terms of surgery, women are more likely to preserve the breasts compared to men who actually insist on a mastectomy. The same way, female gynae oncologists tend to have better outcomes than male gynae oncologists. So there are a lot of instances that should, it might not be specific for low to middle income countries, but as you know, for low to middle income countries, we have less female gender in our workforce, especially at the higher levels in terms of specialization. A lot of women tend to want to leave their specialization because there are competing interests, taking care of the children, not having enough leave to take care of their babies, not enough time to do their work. So they tend to fall behind. They tend to be given less menial jobs in their workplaces. For example, leadership positions with authorship in terms of editorial boards, so many things. There was an analysis in the UICC and looked at cancer organizations. Women tend to be more in like advocacy groups, but less of them were found in organizations like the governments, in the research institutions, and in the hospitals, and in the professional societies. And as I said, these actually impact the outcome of our women down the line. So a lot of things have to be done to improve this, as it tends to translate into outcomes in our female cancers, females with cancer. Next slide. I come from Sub-Saharan Africa, so most of my examples will be from Sub-Saharan Africa. So as of 2020, 463 women were diagnosed with cancer, out of which almost 4 died. They made up 60% of all new cases and 58% of cancer deaths. So women are really marginalized in Sub-Saharan Africa. Next slide. Again, out of the young adults who died from cancer, 4 in 5 were women, just to show you the impact on women. Next slide. Again, looking at the number of patients women who died, leaving a large number of orphans in their society. It was worse for Africa, 35%, and Asia, which make up most of the low to middle income countries compared to more advanced countries. Next slide. In conclusion, we have a large premature death in the region of Africa and many low to middle income countries. Most of the risk factors can be controlled, and there's data lacking for most of these parts of the world to help us to make informed decisions and tailor our practices and legislation to control cancer in these women. Next slide. So our key recommendations will need a coordinated effect from international organizations, national and subnational governments, researchers, research funders, civil society, and private sector to ensure data on sex, gender, and other factors are routinely collected in statistics and publicly reported and updated. We have an example of some countries like New Zealand have given good examples, but for most of us, for reasons that I've given, we need to have enough reportage. For example, in the lung cancer trials, there are very few women who enrolled, so we can't tell what really the impact of these new treatments or screening practices are for women compared to women. There are differences, and that needs to be accepted. We need to design and implement gender and international and intersectional transformative strategies to increase equitable access. I've given so many reasons why the women are more marginalized than the men, first of all, in low to middle income countries. We need to create accessible and responsive healthcare systems to provide respectful quality care for women. There are so many stories in the Lancet Commission that shows you how women are marginalized in different parts of the world. Also something to do with our socio-economic structure, poverty, and health literacy that is worse for women in low to middle income countries than others. We need to strengthen and enforce laws and policies that reduce exposure to known cancer risks for girls and women. Example, tobacco, even beauty products like hair creams, that were found to be associated with endometrial cancer was in Black women. Also, bleaching creams which were found in Black women who importantly are mostly located in low to middle income countries. We need to have equitable access to cancer research resources, leadership, and funding opportunities. There are so many studies that found that funding for women were less even in high income countries. And this is worse for low to middle income countries where we have a lot of patriarchy and we have men leading all these organizations that tend to favor men. We need to integrate a gender competency framework into our education and training of the cancer workforce. By doing this, we'll be able to sensitize our workers into the team approach, policies, and even cancer care that actually identifies the needs of women across their all different diversities. We need to develop, strengthen, and enforce policies that prevent gender-based harassment and discrimination in the cancer workforce to promote women in the workforce that translates into cancer, improved cancer outcomes for women. We need to research, monitor, and act on emerging cancer risks that disproportionately affect girls and women, including occupational and environmental factors, as I've outlined. We need to develop and validate a feminist economics approach to investment cases. So countries like Kenya made an investment case for increasing preventive services for breast and cervical cancer. And indeed, what they found out that we're able to save $2.3 million just by investing in preventive approaches versus treating locally advanced cancer and so many other countries. But these are things that should be encouraged in the different countries to be able to invest in this. The same we have with cervical cancer screening. High income countries have an uptake of 84% versus less than 12%, even low to middle income countries. Unfortunately, most of them in Africa. So there are a lot of things that have to be done to promote investment in these preventive strategies. We need to establish, implement, and enforce pay standards for all caregivers, because that gap down the line creates a lot of problems for the country, for the patients, for children, and for families down the line to come up with fair, equitable, and inclusiveness of our caregivers into our system. This not only just for caregivers, but what we also found out that there was a massive pay gap for female cancer workforce across all countries. But somehow, low to middle income countries have to have less of a pay gap compared to high income countries. But I think we just have to make sure there's equitable access to cancer care and equitable remuneration to make sure that a female patient or cancer care worker feels dignified enough to provide their service and promote other women. We all know that when women are also in the cancer care workforce, they are able to mentor more women and improve the catchment for preventive services, and which eventually leads to reduced mortality, of cancer in our women. And thank you very much.
Thank you, Dr. Vernon. I mean, I just feel like applauding you and the whole team that has been behind this commission. As you were stating in your first slide, it's a huge team behind that for the incredible work and bringing this evidence. And that takes me to the one question that I want to address is why City Cancer Challenge Foundation is interested in gender equity. And because gender equity is a massive issue. It's beyond all of us, beyond cancer. And of course, it's not like the cancer community, certainly we're going to change this very, very in-depth issue we all face around the world. But as this research has outlined, it actually has implications in patient outcomes, massive implications. The health workforce also, implications on the results. Not having leadership in the workforce has implications on the patient outcomes. I was talking with a patient recently, and she was late diagnosed, and I said, "What happened?" She's like, "I went to the doctor over and over and over, and the response I got from my doctor is that I was cuckoo, I was emotional, I was being a bit, very woomy. So that go home, it's hormonal, just relax, you're very stressed." That delayed. So that gender issue had implications on her diagnostic and probably her treatment. And that's just one example of many that I've been hearing from many patients. So City Cancer Challenge, for those who don't know, which I think hopefully from this webinar, not that many, and for the ones that you've just joined, I'm Isabel Mestres. I am the CEO of City Cancer Challenge. We work with cities to improve access to quality cancer care. And for us, patient outcomes is critical. And if this is an issue that is affecting patient outcomes, then becomes an issue for us. And one of the things we are going to be starting to take is taking these results and actually get them into action. Start actually as we generate data on the systems of the city, understand from that data what are those gender issues that are happening in the city, and start finding ways to address them and take that more academic paper into action and start putting some research to see how things could improve for patients. What are the different activities or interventions that could be the best ways to address the impact that this gender equity is having into the patients, both women and men. And I think that's where we're coming from, and that's part of what we're going to be announcing soon. But for us, as I said, it's about the patient outcomes, and then we have to start intervening in all the different spheres: patients, access, quality of the services, policy, health workforce. So we have to start intervening in every of the aspects, generating the data and generating the research to identify what are the best interventions to overcome this additional barrier that I think Tisha was flagging something important. It's true, it's a woman issue, but it gets even more exacerbated when it's an intersectional with other aspects like geography, ethnics, race, and that's where now I think that the biggest drama is happening. So with this, I would like to pass the voice to real example, real life situations of what's happening in the ground and how the people that are facing with all of these, I want to hear their reactions to this research piece. So I think I'll pass it over to them. I think Fatima, you start, if I'm correct.
Thank you.
No, Professor Nur. Okay, over to you, Kata.
Thank you very much, Isa. Now we will continue with Professor Nur Aisha Mob Taif. She is from the University Malaysia, and she is representing also the City Executive Committee of the City of Greater Petaling in Malaysia. Thank you very much, Professor. Please, everyone, remember you can use the Q&A section to leave questions for all of our speakers, and we will address them shortly. Thank you very much. Professor Aisha? Professor Aisha, whenever you're ready, you can start presenting. You are muted now, so we cannot hear you.
Okay, hello everybody. Good evening, good morning, and from any part of the globe. Sorry, I switched on my video. Okay, I think there's some issues with the data. So let me first thank for the invitation to share a little bit of context from Southeast Asian country Malaysia. So Greater Petaling is actually a state, the Selangor state, which includes the Federal Territory of Kuala Lumpur, which is the capital of Malaysia, as well as Federal Territory of Putrajaya, which is the administrative capital, which is home to about 9 million people. So despite being a upper middle income country with universal health coverage, our cancer outcomes are still have not reached its full potential. You can actually move the slide. I can't see the slides moving, unfortunately, from my side. Yeah, so this is a little bit on Malaysia. So, you know, the
We cannot hear you well, Professor Aisha. You seem to be having some issue with your sound.
Catalina, I suggest we move to another speaker while Professor Aisha gets her connection back.
Perfect. Yeah, that's a good suggestion. Thank you, Isa. So let's move with Professor Jessie Gitanga. Please, if you can continue. Thank you very much.
Thank you very much for this permission, opportunity to talk about the situation. And I will concentrate on Nairobi in Kenya. Kenya is in Eastern Africa, and Nairobi is the capital city. If you can go to the first slide, please. So meet Wanjiku. She's the Nairobian woman. She's a typical example of the woman in Nairobi. Nairobi has a population of about 5.4 million, which is 10% of the total population of Kenya. And the females in Nairobi make up just over half of the population in Nairobi. The typical Nairobian woman, the age 15 to 34 years of age, is 35% of the females. The mean age of these females is 25 years. And the population in the informal settlements is approximately 50%. So that means 50% of our women and are dwelling in those slum or semi-informal settlements. The education for these women is lower than for men. And there are significantly fewer women than men in most sectors. And Wanjiku, therefore, is mostly young, living under a patriarchal system, and has a limited voice and low spending power for health. And this is the woman who will be charged with looking after your cancer patient, an elderly person with cancer, or even a middle-aged person with cancer, etc. Next slide, please. Next slide. Is her cancer journey. Sorry, you've gone too fast. The previous slide. Yes. A healthcare system that is difficult to navigate. We are a low middle income country, and whenever a patient has cancer and is referred, it's very hard to get to the cancer treatment center, which is mostly in the capital cities or the bigger cities, and it's hard to navigate. There are delays in getting an accurate and timely diagnosis. And health insurance, there is low national coverage. Most people of these 7 to 10% who have insurance rely on the National Health Insurance Fund. And this fund has huge gaps in the benefit package, and almost every patient has to go back into their pockets, despite this insurance, to pay for costs. And there are many social cultural barriers. Not only is this a patriarchal system where the woman may not have much of a voice, there are few opportunities or access to support for these women who get cancer, and they're the most caregivers. And also the social norms, the stigma, the fear, the myths, all these will delay our patients seeking care early. Next slide. So how do we break these barriers? We need to expand the coverage of the National Health Insurance Fund so that it benefits more people, not just that 6 to 10%, and all social securities are met. We need to improve access and navigation of the healthcare system, make it easier for a patient who's diagnosed with cancer to access that care without having to move back and forth all over the place. We need to improve the quality of care for early detection, screening, and diagnosis. And here, I'd like to point to something simple like vaccination for the human papilloma virus, which can prevent almost all cervical cancer cases. We only have penetration of up to 20%. And those myths, those issues that I mentioned are preventing having more patients or more potential girls being vaccinated. We need to use evidence-based approaches to care. There are things that we know do work and can work in our society, and we need to use those approaches. More research, and I'm glad this was mentioned even by the previous speakers, more research on the cost of cancer, and especially on the gender-related aspects of cancer care in our setting. Finally, we really need to nurture more strong women advocates. Women advocates, not only at the higher echelons of society, but even amongst the local community, have strong women whose voices are listened and whose voices are heard. Because without that, women making more than half of the population, we will lose our battle against cancer. Thank you very much. And I welcome any questions in the Q&A session.
Thank you very much, Professor Jessie. Yes, everyone is welcome to.
I am through.
Thank you. Everyone is welcome to leave the questions in the Q&A section, and we will address them shortly. Now we will move on to the next presenter, Fatima Luna. She is also a representative from the City Executive Committee of SICAN in the city of Arequipa in Peru. So Fatima, please.
Thank you, Catalina. Firstly, I would like to thank SICAN for inviting me to participate in this great and powerful panel. I will briefly discuss how the findings of the Lancet Commission that Dr. Berna presented are pertinent to Peru and outline potential pathways to advance an equity agenda for cancer. So next slide. What are the challenges? What challenges do gender inequalities pose in cancer care for a Peruvian perspective? People with a lower socioeconomic position has worse health outcomes and higher mortality rates from cancer than other groups. Now consider a Peruvian woman living in poverty, belonging to a marginalized indigenous group in a rural area facing a disability that need to travel a day to see a doctor. What are her chances of even receive treatment? Another one is burden of care. Caregivers support patients financially, physically, emotionally, and socially, and take on many responsibilities to meet patients' needs. Data from the Peruvian Cancer Foundation Patient Support Program indicates that 64% of caregivers for cancer patients are women. 2023 was recorded as the worst year for violence against women, with Lima and Arequipa having the highest rates. Violence breeds, as you know, submission, fear, and isolation. In the migration topic, whether internal or international, migrant women encounter linguistic, cultural, and structural barriers. Peru ranks right now as the second largest destination for migrants and refugees from Venezuela globally. Regarding the access factor, I would like to highlight the geographical barrier, which is similar to what Professor Jessie mentioned before. Cancer care services centralized in Lima, our capital city, forcing more than 60% of patients from remote areas to travel long distances to the capital, and women are less likely to leave their families to seek diagnosis or treatment, leading to the higher rates of treatment abandonment. This lack of access to preventive screenings for early detection contributes to late diagnosis and worse outcomes. About emotional and psychological burden, women face greater emotional and psychological challenges during cancer treatment and survival. One of the findings at our patient program is that 75% of female patients require our psychological support. In addition to that, there are social factors that influence health, such as unemployment and poverty. Next slide, please. And this is our pathway forward with policies and guidelines. I summarize some of the topics that were mentioned by previous speakers. Having data is the basis of everything. It will allow an effective intervention plan. Incorporating gender disaggregated data into policy making is crucial to equity in cancer prevention and treatment. We must keep reducing financial barriers despite the national cancer law that we have in Peru, which ensures universal and free cancer care. Financial barriers continue. We need to tailor care models to meet the specific needs of women for a better quality and experience in cancer care. A comprehensive support is also critical. Provide emotional, psychological, and social support throughout all stages of cancer treatment. Educating and empowering women about their rights and involving them in policymaking and health services planning is essential steps in closing the gap. Investment in research, you already told it, because without research, there's no progress. And finally, collaborating international races efforts to address the unique challenges faced by women in cancer care. And Tisha mentioned at the beginning of this webinar, organizations like SICAN can play a critical role in fostering cross-sector collaboration to tackle social determinants of health and narrow the gap. Thank you.
Thank you very much, Fatima. And Professor Aisha, did you manage to solve your problem with the sound? Let us know if you are there. Otherwise, we have a few questions from the audience. That maybe I saw that Dr. Berna was already answering some questions in the Q&A. Thank you very much, Dr. Berna. But I was particularly interested in this question from Filipa de Quir. I'm going to read it. This is, how can empowering women in the context of cancer contribute to a more resilient and informed approach to prevention, treatment, and support? Maybe, Berna, you want to expand on that?
Well, I thought that putting women in leadership positions would be the first step, because like I said earlier, anytime you put a woman leader, they are more gender sensitive, and they are able to identify with the roadmaps and the barriers to cancer care, maybe not in their country, but even from other countries as well. So I think that is the first step. Women have been relegated in the background for so long, and for so many reasons globally. Nothing to do with low income, but of course it's worse, for us. And also we are able to develop more mentors. So like in preventive strategies, every country is different, every community is different with their values and their cultural sensitiveness. So if you put a woman there, they'll be able to change or implement various strategies that will increase uptake of screening practices or knowledge sharing or education. There are so many countries that have actually shown that when women participated in cancer screening or even primary taking care of the patients, there's an increased uptake in screening, especially for breast and even cervical cancer screening, also because of the social impact of men and doing these procedures on the women. For example, even with colorectal screening, nobody really talks about that, but we know that with colonoscopies, it's actually worse than doing a pap smear. You really have to strip naked, and that has a lot of cultural inhibitions and leads to less women coming for this screening. I think by increasing women at the forefront of nurses, technicians, physicians, I think a lot more, can be done to improve. And these women even giving out messages and finding out champions and survivors, educating our survivors, strengthening our survivors, we're able to draw more people into, the network of prevention and early detection. So I think this is also in terms of national cancer control planning. Again, we need people who can sensitize and identify with the women. And I think this is a very big step. We are missing a lot of that. A lot of the cancer control planning doesn't really segregate the data. There are not special recommendations for alcohol intake for women and tobacco for women and beauty products. But these are things that interest us much more than they do men because they affect us and our children. So I think that is the beginning step. And also legislation. I think when we have more women that control the law and policies, I think that also do a lot to translate into improved control measures and that impact women. Yeah.
Thank you very much, Berna. That was very insightful. We have time for one more question, and then we will move forward to our big announcements. So the last question that we have is the question from Gloria Orji. And she mentioned that a lot of discrimination against women happens in the hospitals, as someone mentioned before. And unfortunately, most women never speak up. So how can we empower women so they can speak up, but also how can we let them know that they are not alone? This question was a little bit more directed to SICAN. So maybe Isa, would you like to go after that question?
Yeah, well, I don't know if any of the other speakers wants to comment on this before I speak, because I think there's a lot to say on this question.
I think so. Yeah.
I know.
I think I'll say that we ignore the role of navigators, and I think female navigators is a big gap in low to middle income countries, and we need that. Somebody who hold your hand, identify with you. I've seen the experiences of so many women. Most of them might be cancer survivors or not, or even healthcare workers who have seen all the problems, all the barriers that are associated with that particular healthcare system. So they are sensitive to it. So by holding your hand and being with you at the physician to be able to voice out even your I realize that the nurses actually do better, with that, because they can identify patients who have social problems, economic problems more than the doctor, or so they are able to come in and step in and allow these patients to voice up their concerns, and that will impact in I think that is it's a missing step, improving navigation services, and it has to be a gender sensitive approach, to doing this. I think it makes a lot of difference. So Isabel, over to you.
I totally agree. I think the patient navigation has become a flagship program for SICAN because one, it addresses patient centricity. We've seen incredible improvement on patient satisfaction, which is important. But the other, of course, the improvement we've seen, which is actually outcome patient, is the reduction on time and on the different interventions of the cycle, from symptoms to diagnostic to treatment. Actually, in Kigali, the patient navigation program has reduced for breast and cervical cancer patients 82 days diagnostic to treatment down to 28 with a patient satisfaction, because again, they are less lonely, they're supported by other female, and it's just like the quality of the journey improves and the results of the journey are clearly in terms of patient outcomes. So patient navigation, it's a no-brainer for us. It's the one, and if you combine that with the training of the nurses, the clinicians, the patient navigations, and you add some of these gender issues, definitely increases even more the quality. And combined with a digital solution, that's another way we've seen to be able to measure progress, impact, and patient satisfaction. So I think that's definitely one. And the other thing, and I think I'll go now to the announcement, and it's linked to SICAN has been for now supporting leadership training skills. So one of the things we've seen in all our cities is the leadership skills are not trained in the health let's say, universities or schools, different studies. It's to focus on the more technical aspects. And we've been doing, and that's actually Catalina who's been leading the work in training leadership skills across the whole community working in cancer care. Specifically, we also did we did a specific program where we granted 10 women for a leadership course. It was a full year leadership course. And we just got recently the results. And, out of the 10, 5 concretely got a leadership position, and they assigned it to the leadership course that they felt they were not alone, and as simple as they felt that they could ask. And that has now, and they are now in actually the 5 of them in incredible leadership positions. The other 5 are also doing good, but that's a very concrete result that I wanted to share. And linking that experience with the Lancet, what I'm here today to launch is that in our SICAN spirit, we always try to ensure our SICAN is locally led, that we respond to local needs. Therefore, we need to bring the local voice in our strategic thinking and strategic planning. So we are launching a working group to support SICAN on how to build a gender-responsive healthcare system for cancer care. So it's a working group for women that are working in cancer care, medicals, academia, public health, civil society, private sector, that want to work with us in this journey to define SICAN strategy to respond and come up with a gender response health system, and what could be SICAN's contribution and where we can have our biggest impact throughout the SICAN model. So this group of women are going to be working with us in defining SICAN strategy, and they're going to be virtual discussions. And the idea is to launch the strategy during the UN National General Assembly in New York. And I want to announce another thing, and I'm very pleased, thank you to the Siemens Healthineers team, is that not only is important that these women support us to come up with the strategy, but they're going to be supported to go to New York to launch the strategy themselves. And it's important. And for me, super important. And I thank a lot our partners to support financially this effort, because it's about raising their voice. It's about starting to change the voice that is always repeated in UNGA and others, because it's cost to go there. So it's always the same people that were there raising the same. So what we want is to start changing the landscape of these global discussions and bring the local voice. So what we're looking for is working with our partners, Siemens and many other partners that are working with us to make sure that they have a voice on all the different events that are happening in New York. Let's get this woman on stage. Let's get the woman to share what are the needs so that the whole global community stands responding to the real local needs. So we're very excited. I would like to thank so much Siemens Healthineers for listening us, for really understand why it's so important to bring the local voice up and helping us in this journey. Thank you. Thank you so much, Tisha. Please send my thank you to Bern, to the CEO and the whole team, because I think that having them in UNGA, of course, they're going to help us with our strategy, but we're changing. We need to change that voice. So thank you so much for supporting our request. And I think the link is here, not Kata, because it will be, the deadline is the 22nd of March. So please share it across your community. We need to get those great leaders that are ready to go to New York and make it.
Thank you, everyone. That's all for today. This session was recorded and it will be uploaded to SICAN website and SICAN YouTube account. Thank you very much. And let's remember to all celebrate International Women's Day tomorrow. And let's use the hashtag #InvestInWomen. So thank you all very much. Bye-bye.